Good afternoon and welcome. My name is Amy Cross, and it's a pleasure to welcome you to Molecular Labs webinar on understanding why infections trigger autoimmune encephalitis and neuropsychiatric disorders, and how the Cunningham panel can aid in your diagnosis and treatment. Leading tonight's discussion is Dr. Craig Shimasaki. Dr. Shimasaki is the co-founder and CEO of Molecular Labs, a neuroimmunology precision medicine company focused on identifying the underlying roots of neurologic, psychiatric, and behavioral disorders triggered by an autoimmune response. Dr. Shimasaki started his career at Genentech and has been in the biotechnology industry for over 35 years. As a scientist, his work spans all stages of research and development, from bench to bedside. His research included epitope mapping for an HIV vaccine, genetic breast cancer risk prediction biomarkers, a rapid influenza diagnostic, and therapeutics for infectious diseases, neuropsychiatric disorders, and noise-induced hearing loss. As a business person, he co-founded multiple companies and led multiple products through the FDA approval process, and is a co-inventor on multiple patents. Dr. Shimasaki received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology from the University of Tulsa, and his MBA from Northwestern University's Kellogg School of Business. He is an adjunct professor at the University of Oklahoma Price School of Business and teaches biotechnology entrepreneurship. His passion is to help translate scientific and medical discoveries into acutely needed products so that more patients can live healthier lives. So without any further delay, Dr. Shimasaki, the floor is yours.
Well, welcome, and thank you for taking time out of your busy schedules to listen to some information, data, and I think clinical and medical evidence that will help not only in your practice, but also, I believe, may help in a broader based understanding of why neurologic, psychiatric, and behavioral disorders seem to be, in many cases, resistant to various types of treatment. So with that, let me go ahead and give a couple of disclosures here. I am the CEO and co-founder of Molecular Labs that performs the autoimmune encephalopathy, basal ganglia encephalitis, what we call the Cunningham panel. But any data that I'm going to share today will be from peer-reviewed publications, and it'll be either that or current research that we've actually conducted here in our laboratory. The other disclaimer is this information is intended for informational purposes only, and it's not intended to be a substitute for any kind of medical care or healthcare providers' guidance. So what I want to cover today are 4 topics. One is the challenges in the diagnosis of these various neurologic, psychiatric, and behavioral disorders, and then briefly speak on various types of autoantibodies against central nervous system targets. And then I want to share with you the biological targets in the autoimmune encephalopathy, basal ganglia encephalitis Cunningham panel, and why they are significant and what their normal function is. And then I want to share with you some commonalities in patient presentations that are associated with what we find in positive patients that have these anti-neuronal antibodies. So we've tested now over 13,000 patients in and out of the country, clinically and through our commercial laboratory, and there's various things that we found that are common in these patients. And then I want to briefly share with you some of the therapeutic modalities that have been shown to be effective in these patients once they have been identified as having an autoimmune encephalopathy. So with that, let's get started, and also we'll have time at the end for questions and answers. So these various types of neurologic, psychiatric, and behavioral disorders are diagnosed by symptoms, not etiology. So for instance, something such as having motor tics or vocal tics for more than 12 months, by definition, this is the diagnosis of Tourette syndrome. hyperactivity, various types of irritability, aggression, rage, separation anxiety could be a diagnosis at some point, ruling out other things for ADHD, and the list goes on. The point here is really that psychiatric disorders are diagnosed entirely by clinical presentation and not by biology. The issue, though, is that most all of these disorders, and probably a very good portion of these disorders, have varied responses to treatment. So it leads us to the understanding that these are likely spectrum disorders. Excuse me, I think I've got a little bit of allergies here. But the standard of care for neurologic and psychiatric and behavioral disorders focuses on symptoms. And in many cases, it's coping with these symptoms. These include psychotropic drugs, psychotherapy, and even in many cases, institutionalization at some point if none of these are effective. We also know that the increasing usage of various types of psychotropic drugs, this is older data, but you can see the tens of millions for various types of psychotropic drugs. Now, we know that many of these are also effective in various conditions. But if we're looking at syndromes that are spectral disorders, and there are patients that are not responsive to it, we want to ask the question, what is the etiology, or what might be the etiology? The other confounding component of this is that many of these psychotropic drugs contain black box warnings by the FDA, and you can see here that the suicidal rate in the usage of these tends to be escalating. So I want to talk about brain-reactive autoantibodies, but they have been known in medicine for a long time. In fact, there's a lot of them, but many of these that we're talking about here in this slide are rare. These are antineuronal antibodies that have very similar mechanisms where they bind to various types of receptors, or what we call G protein coupled receptors, or interfere with different types of targets that are on the external surface of, in many cases, human neuronal cells. Many of these have been associated with paraneoplastic syndromes, meaning that they're triggered or a result of or coexist with various types of neoplasms. But the ones that we're going to talk about today are not those. We're going to talk about very similar types of autoimmune neuropsychiatric disorders that have autoantibodies associated with them. So there are other CNS autoantibody targets that do result in these autoimmune encephalopathies. Lots of published literature showing that these autoantibodies that are made actually cross the blood-brain barrier and interfere with neurologic transmission in the brain. So I did a PubMed search on the term autoimmune encephalopathy, and you can see the very exponential growth of peer-reviewed publications about clinical studies, about case studies, and about research in autoimmune encephalopathy. Other terms can be autoimmune neurology, immunoneurology, neuroimmunology, neuroinflammatory disorders. But these have all continued to grow in their publications. You might be familiar with one such case that has made it into Hollywood. It's the antineuronal antibodies that were directed against the NMDR receptor. Susanna Cunningham also wrote a book called Brain on Fire. She experienced a sudden onset of psychosis, hallucinations, paranoia, and really had stumped many of the doctors until one actually identified and understood that these autoimmune antibodies that cross the blood-brain barrier actually can cause and create these symptoms. But again, the ones that we're referring to in these previous slides here are historically known, but they're not as common, so they become more rare and more difficult to identify and diagnose. But what I want to talk about are antineuronal antibodies that are more common, that interfere with neurologic transmission when they cross the blood-brain barrier. So these antibodies that are generated through what I won't go through today called molecular mimicry, and these are infection-triggered autoimmune conditions, that when they cross the blood-brain barrier, they actually interfere with various types of receptors that, such as the dopamine D1 and D2 receptor, and trigger these neurologic and psychiatric and behavioral symptoms. Other studies have been published on children with obsessive compulsive disorder and tics that are associated with a streptococcal infection, resulting in brain inflammation. So this is a study showing a number of children who had inflamed caudate globus pallidus putamen, but not in the thalamus, which is not in the basal ganglia. And the basal ganglia is responsible for certain types of bodily functions, like voluntary motor control, procedural learning, cognitive functions, and various emotional functions, and eye movement. And so what you'll find as we move into the symptoms associated with these anti-neuronal antibodies, you'll see a very clear correlation with these functions within the basal ganglia. So the question comes, can infections really trigger neuropsychiatric disorders? This is a publication in JAMA Psychiatry in March of 2019. What they did was a study of over 1 million individuals in Denmark that had medical records from birth to age 18. And what they found that if a patient was hospitalized for a severe infection, that the risk of developing mental disorders increased by more than 80%. And these diagnoses were schizophrenia, autism, OCD, ADD, ADHD, personality behavioral disorders, and the list went on. So in an accompanying editorial, they said, how could exposures to infections affect the brain mechanistically to give rise to mental disorders? The answer, they said, was circulating autoantibodies that enter the brain via a compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation. And this mechanism has been proposed in pandas and other mental disorders. So you may or may not be familiar with the term pandas as it relates to these neuropsychiatric disorders that are identified in children post-infection. But it is a very important model as we talk through this. So let me do a little bit on the nomenclature, because this is also confusing or can be confusing, but it is very important as we walk through this. So PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder associated with a strep infection. There are also other microbes that are now known and identified and associated with infection-triggered autoimmune neuropsychiatric disorders. These include Lyme, Mycoplasma, Babesia, Bartonella, and several others, and I'll briefly share why that's the case. But they're also believed that there are environmental and other biological factors that can trigger these same things. So in pandas, we're talking about strep. So there became a nomenclature issue that was addressed by the term PANS. So a group of physicians, researchers, and various types of disciplines met at Stanford to coin the term PANS, and it's pediatric acute onset neuropsychiatric syndromes. And that encompasses all of these. And there's a publication in 2015 describing that. And there's several publications that are involved in actually showing various types of treatment, which we'll discuss in a minute. We also know that children grow up to be adults, and there's been other proposed terms, such as the term ANDL, which in this case is autoimmune neuropsychiatric disorder associated with Lyme, also kind of sometimes used as adult neuropsychiatric disorder associated with Lyme. So what we're finding now is the terms autoimmune encephalopathy, sometimes secondary to infection, or basal ganglia encephalitis. And sometimes these terms have other connotations. So encephalitis, basically, as we know, is just a term that means inflammation of the brain. encephalopathy is any disorder or disease of the brain. Often, though, encephalitis is a connotation of a direct infection, whether it's bacterial or fungal. But we also know that these are rare conditions. But encephalitis in connotation terms sometimes is thought of as this direct infection of the brain, whereas basically in these cases we're referring to it as just inflammation, brain inflammation. So how does this occur biologically? That's a really good question that was alluded to in the journal there. We all get exposed to bacterial, viral, and fungal infections, and our body produces antibodies that recognize these infectious agents. And these infectious agents trigger antibodies that are directed against specific portions of those targets. We're very familiar with that now with SARS-CoV-2 and the importance of antibodies that are directed against specific targets. Well, in these cases and in certain patients, that the antibodies that they develop actually cross-react with these neurologic receptors in the brain in a method we call molecular mimicry. And once that happens and they cross the blood-brain barrier, which the blood-brain barrier is more permeable than we previously thought, and that the brain is not always as privileged an area as what was thought biologically prior to maybe the last decade, they do interrupt the functions of these neurotransmitters and these receptors. And through what we might think of as friendly fire, they cause and trigger these neuropsychiatric syndromes, which can be heterogeneous depending upon the target in which they're actually directed against, which also makes it much more complex and confusing. And the standard of care, as mentioned, is various types of psychotropic drugs. But in these patients where the biological etiology is autoimmune, these tend to be ineffective, and in many cases, and often cases, many of these neuropsychiatric drugs can potentiate or actually in some cases make it worse. We also know that SARS-CoV-2 has helped in one way to help us understand the association between the immune system, a normal functioning immune system, and an immune system that's not, let's say, maybe hyperactive, but not normally functioning in a way that it should, where it triggers a inflammatory response, autoimmune response, resulting in what is now known as long COVID, and then various other types of syndromes similar to myalgic encephalomyelitis and other types of inflammatory syndromes like Kawasaki-like syndromes. Well, lo and behold, infection-triggered autoimmune neuropsychiatric disorders are not new. In fact, rheumatic fever is a condition triggered by strep, group A streptococcus. But the component that is associated with that, or the neurologic manifestation of that, is Sydenham chorea. And Sydenham chorea we don't see as frequently anymore in the United States, but it is still around. And it's characterized by abnormal loss of fine motor control, but abnormal movements and emotional control. And again, you can see the commonality between that and the targets in the basal ganglia. And what we see is that group A strep will generate these antibodies in certain patients that are common as targets in the heart, specifically certain types of proteins, which results in rheumatic fever, and the treatment is penicillin or antibiotic. And then in many patients that are related to this, the neurologic manifestation of rheumatic fever can be Sydenham chorea. So there are other infections that are found to be associated with these infection-triggered autoimmune conditions. And the list is here. Group A strep, as we mentioned, which is what's really directed as the name pandas. Influenza A has been known to do the same. We also know that influenza A has been associated with narcolepsy, another infection-triggered autoimmune condition. In fact, even the vaccine has also been associated with that because it is basically the proteins of the influenza A virus. Varicella, Mycoplasma, Lyme, or Babesia, Bartonella, Coxsackie virus, and others. So these are the most commonly associated ones. And although I won't go into it in much detail, it's because there are common sequence similarities within the peptides or the proteins of these particular organisms that if an antibody is developed or made against those specific parts or what we call epitopes, the result is a cross-reactive antibody. The great thing is that what we see is some really amazing patient recoveries when they're properly diagnosed and treated. We have lots of great stories like this with Adam, who was diagnosed with ADHD. They thought he also had autism. They were being prepared, the parents were prepared to put him in an institution. They found out about our testing. He received the proper treatment. He's now completely well, and just a while back, his mother sent us this picture of him running cross country in high school. She said recovery is possible. He's 10,000 times better. And then one more of Grace, who was diagnosed with ADHD and OCD and other mental disorders at age 8. In fact, she was wanting to kill herself. And suicidal ideation is also one of those things that do show up in these patients. The parents said they emptied their 401k twice with no answers. Again, they found out about her testing. We tested her. Her treatment was changed. And just recently, she sent us a picture of her on the cheer team, back to normal life. And so we have many, many stories of this and off all medications. So it is something that's very rewarding to know because patients such as these often end up with a lifetime of various types of psychotropic meds, and sometimes, unfortunately, maybe end up in institutions. So your challenge really as clinicians and patients with autoimmune neuropsychiatric disorders is kind of like what this cartoon depicts, is that often in medicine, it's not always rewarded to think outside the box. But these are complex conditions. We'll talk a little bit more about how the panel and the targets in the panel can help you in your diagnosis and even the treatment of patients. So now we're going to move to what are the biological targets in autoimmune encephalopathy, basal ganglion encephalitis, Cunningham panel, which will probably transition to that particular name. But it was based on 15 years of Sydenham Korea research. And if you remember, it's a strep-induced infection that caused cross-reactive antibodies to result in these neurologic and psychiatric and behavioral disorders. So in the panel that we now make available is 4 biomarker targets and a cell stimulatory assay. And I'm going to go into this in a little bit more detail here. So the 2 targets here are dopamine receptors. There are actually 5 types of dopamine receptors in the brain. And these actually are the ones that appear to be more highly associated, more frequently associated. They interfere with the receptors in various ways, and I'll talk about that a little bit more in a second. The lysoganglioside, which is actually in the myelin sheath surrounding the nerves. Tubulin, which is an intracellular protein that is highly concentrated in brain cells. And then this calmodulin CAM kinase activity, which is actually a cell stimulatory assay. And this assay is also very important. It's very highly complex for us to perform it because it's a radioisotope assay. But it is important because the antibodies will stimulate the activity or upregulate this activity. And why is that important? Well, because calmodulin CAM kinase is involved in the synthesis and the upregulation of the neurotransmitters dopamine, epinephrine, and norepinephrine. So what you can see pictorially here lysoganglioside on the myelin sheath, dopamine D1 and D2, tubulin inside the cell, and then internally, these can be triggered to activate the calmodulin CAM kinase that results in the upregulation of dopamine neurotransmitters. So I want to briefly share with you the results in the laboratory format of what we call the AE-BGE Cunningham panel. If you perform or actually order a test and run that, you'll get the results that look like this. So you'll see the first page, which will be the 5 panel test results that'll indicate whether they're inside or outside of normal controls, and it'll be interpreted up there. The second page is actually a brief explanation of the biomarkers, similar to what I'm going to go through today. Also, the sensitivity and specificity currently understood for the testing of these. And then in page 3, you'll see the symptom correlation that I'm going to go through here right after in just a second. And then page 4, laboratory accreditation, which is important. We've been inspected 7 times by the CLIA and COLA. And then the biology of these targets, what the normal function of these targets are. And then page 5 will further explain more of these targets and what their normal function is. And then page 6 will have the remaining targets and then also literature references. So page 8 through 21, it's available there, and it's with every report, is the Journal of Neuroimmunology peer-reviewed publication that will give great detail about including the data that I'm going to share with you. So if we look at the target of dopamine D1 and D2L receptors, these two are what we call G protein coupled receptors that are transmembrane proteins, just meaning that they're embedded in the membrane, and then they also respond to dopamine neurotransmitters. Well, if you have antibodies that either interfere, block, bind, or what we call allosterically affect them, you're going to have interruption with normal function within the dopamine D1 and D2 receptors. So patients that are positive for autoantibodies with dopamine D1, we frequently find them associated with more psychiatric symptoms, and they also correlate with mood instability, anxiety, irritability, etc. There are other types of symptoms because they're so heterogeneous, and those are listed here and in the report. For the dopamine D2 receptor, we see this more frequently associated with various types of motor movement types of symptoms, like choreiform movements and other types of things, including hyperactivity. So for patients that have positive autoantibodies against tubulin, and tubulin is an internal cell surface protein, it is also associated with other types of autoimmune disorders. Antibodies against tubulin have been seen in Hashimoto's thyroiditis. So we see that in the context of these tests, it's often associated with OCD and cognitive interference, or what may be referred to as brain fog. And we also see others, various types. You can see the percentage of association in various patients. Again, these are listed in the report, the pages behind the report format. And then antibodies against lysoganglioside GM1, remembering that these are the myelin sheath, they are involved in the myelin sheath around the nervous system. We see them associated more frequently with tics or complaints of joint and connective tissue pain. But again, there's frequency seen with sleep disturbances and other sensory abnormalities and behavioral regression. And then we get to the cell stimulatory assay that we call calmodulin CAM kinase 2. We see that it is involved with the sympathetic nervous system, meaning that you'll see fight or flight behavior, such as separation anxiety, things such as sensory sensitivities, even urinary problems, bedwetting. The one interesting thing about this particular assay is when it's elevated, we do see it very, very highly correlated with either a new infection, a reactivation of infection, whether it's clinical or subclinical. And often it's also a trigger to know that there's some infection that does need to be identified or treated. Again, other things such as involuntary movements, things like that. So the reason that calcium-dependent calmodulin kinase 2 is important is because what you can see here is that it's also involved in many of these other types of receptors in the nervous system, the brain. And many of these are associated with some of those conditions that we described that are more rare. There's a lot we still don't know about calmodulin protein kinase 2, and we're also doing research here to identify and understand this. And as we do, these things will be published. So I want to briefly share with you the published study on the evaluation of the Cunningham panel, looking at the presence of these antineuronal antibodies and how closely did they correlate with symptoms. So, and before and after treatment. In the cases where treatment was effective, what's the correlation with that as far as these autoantibodies being present or absent? Again, this full publication is attached to the back pages of the report. One of the things that we found that was very important in all of these patients is they had multiple infections. So at least one, but most all of them had more than one infections, and these were we'll call them the bad actors. They tend to show up. Now, again, I mentioned some of these as being common with epitopes, but because many of these patients have a compromised immune systems afterwards, you see many of these others that may be bystander type of infections. And the symptoms of these patients, as you can see, all had various types of neurologic, psychiatric, and behavioral disorders. They were all either diagnosed or suspected diagnosed with PANDAS. So PANDAS, again, think of it as a medical model for various types of these syndromes we're calling autoimmune encephalopathy or basal ganglia encephalitis. So let's look at the data. This is the heat map of the individuals who were in the cohort that actually improved after treatment, but this is prior to treatment. What you can see here prior to treatment, all of these patients had one or more positive antineuronal antibody target in their panel. So they were all also presenting with lots of symptoms. In this group who actually improved after treatment or completely resolved, so they either improved or the symptoms completely resolved, this is their post-treatment panel results. So you can see a dramatic change in the number of antibody positives, as well as a dramatic change in the frequency and the number of them positive. And this is just another way to represent the number of positives, but also those that are after treatment. I won't take time to show the ones who didn't improve, but they're basically the opposite of this. So one other piece is just to quickly share with you the sensitivity and specificity calculated as if these antibodies were present and the patients improved, or if the antibodies were not present and the patients did not improve, the antibodies were present and the patients actually had the symptoms, or that they didn't and they were gone. What you can see here is 88% sensitivity and 83% specificity, leading to an overall accuracy of 86%. Now, one of the things we're doing on the research side is because not all these targets may carry as much weight as far as the information, that we've developed some logistic regression algorithms that weight them differently. And in doing so, we can increase the accuracy up to 90%. We're also looking at ways to add additional markers because we would like to get this up close to 100%. I'm going to give you 4 case studies just so you can see the practical nature of some of this. This is a 24-year-old young man who had symptoms of OCD and motor tics. Decreased appetite is another hallmark, but he lost 30 pounds, increased ability to concentrate. And again, this decreased appetite is not necessarily a body image issue, or that it's often an OCD that's a fear of choking or food contamination. Sensory abnormalities, emotional ability, etc. And you can see here that this individual had one positive test, which is why we run all 5, and that was the calmodulin CAM kinase. He was treated with IVIG and plasmapheresis. All his symptoms were resolved, and you can see all his antibodies were back into baseline. This is a 9-year-old young girl who had OCD, verbal tics, and autism-like stimming behavior, difficulty concentrating, behavioral regression, urinary and sleep disturbances, dysgraphia, difficulty writing, and relapsing remitting in nature. She had 2 positive targets, 1 borderline. Again, this individual was caught early. I believe this is one that had a subclinical infection and was treated with azithromycin, and rapid improvement, all of her symptoms. In fact, everything went back to baseline. So another case of this patient who actually is one of the peer-reviewed published studies, a 9-year-old girl who had Lyme and then also had various types of neurologic and psychiatric problems positive there. She was treated. As you know, Lyme is sometimes very difficult to eradicate. Multiple antibiotics and then immunotherapy, but all her symptoms resolved and all her antibodies went back to normal. A 9-year-old young man who, after 30 days after a strep infection, developed OCD. Other types of disorders you can see associated here. Again, a single positive test, and treatment had IVIG, and within 1 month was completely symptom eliminated. I won't go through all of these, but if you'd like, there's other publications in the area of patients that have autoimmune encephalopathy associated with autism, in Lyme, neurologic Lyme, also in schizophrenia, because remember, these are diagnosed by clinical symptoms, and it's more like a spectral disorder. So let me wrap up here with what does this mean, and then also some commonalities in the patient presentations. So there are commonalities in these patients that we find that are positive for these anti-neuronal antibodies. Some of these are sudden and rapid onset of neuropsychiatric symptoms. So that's one of the signs. In fact, it's also one of the criteria for diagnosing with PANDAS or PANS. Sudden or rapid onset of OCD, various types of restrictive eating disorders. Again, these are fear of food contamination, fear of choking, motor or vocal tics or choreiform movements, anxiety, rage, separation anxiety, inappropriate for age, emotional ability, depression, developmental behavioral regression, mydriasis, dilated pupils. Again, remember the fight or flight syndrome, the sympathetic nervous system, which is being activated, urinary frequency, bedwetting, and then relapsing remitting course with dramatic abrupt exacerbations. So again, that's also a hallmark of a diagnosis for PANDAS and PANS. Suicidal ideation is also frequently associated. Often patients won't tell you that, but if you ask them, some of our clinicians say every one of them has admitted to that. Treatment resistance to standard neuropsychiatric drugs. PANDAS and PANS diagnosis or symptoms, obviously. Typically, they have family histories of autoimmune disorders, and then a frequency of infections. They can be subclinical, but again, generally we find that to be the case, such as either things like neurologic Lyme or what's called post-treatment Lyme disease. So the goal of precision medicine, and specifically where we're interested, is to diagnose and identify patients who would respond to anti-inflammatory, immunomodulatory, or anti-infective therapy. So if you take an example of patients who are all presenting with various types of neurologic, psychiatric, and behavioral disorders, the goal is to separate those that would be infection-triggered autoimmune and those that are other etiology that would respond to traditional psychotropic medications. Within this group, we're also working on studies and algorithms to predict which of these patients, based upon their testing results and the history that we have, responsiveness to some of these types of therapy, like IVIG, plasmapheresis, rituximab, steroids, or antibiotics. So moving over to what therapeutic modalities have shown effectiveness in treating these patients. Because clinical effectiveness has been demonstrated when there is biological evidence of autoimmune neuroinflammation, which is important. These include, they fall into the group of anti-infectives. Obviously, if you've got a subclinical infection that's stimulating these autoimmune antibodies, you want to get rid of the infection. And you want to find them because, remember, there's multiple infections often found in these patients. Anti-inflammatory agents, because these tend to be effective because they're basically brain inflammatory. Immune modulators in patients that don't completely resolve based on the first two, because, again, remember, the immune system generates memory B cells. And over time, these memory B cells become pretty strong and continue to produce and secrete antibodies. The other is some temporary symptomatic treatments, but also remembering that specifically standard dosing of psychotropic drugs tend to be not effective and in some cases deleterious. So they can fall into these four categories. The medical model for what we'll call autoimmune encephalopathy and basal ganglia encephalitis is PANDAS and PANS. So in PANDAS and PANS, you all want to rule out any other kind of diagnosis, meaning, can it be something else? But you also do want to think, can it be autoimmune and infection triggered? So you treat all of the infections, whether it's viral, bacterial, fungal, of any sort. Sometimes you have to provide symptomatic relief as necessary, but then if the patient is not completely recovered, treating the inflammation and the immune dysfunction. And there is a very good group of guidelines for PANDAS and PANS in the Journal of Child and Adolescent Psychopharmacology. So they give you an overview of PANS. Remember, think of this as a medical model. Again, this is referring to children, but clinical management of that for the psychiatric and behavioral interventions, the use of immunomodulatory therapy and anti-inflammatories, and then other types of uses for treating the infections. We also want to advocate that you take advantage of the pre-consultative services that we have at Molecular Labs. We provide that free to healthcare providers on the laboratory results. So when you get your laboratory results, you'll see that there will be a phone number directly for physicians. You can contact us directly at this direct phone line, or Amy Cross at this email address. Any logistical questions or other questions, you can directly call our office, and everyone here is happy to help. We also have free in-service education on symptom association and biological targets, very similar to what I talked about, but more detail. And that's available either for your colleagues or office staff, or if you have a multi-practice specialty. We also have free resources, publications, videos on our website at www.molecularlabs.com. And then there's also downloadable, or you can order, and we'll send you hard copy educational brochures that you can just leave in your office or give to your patients, because often it does take a while to explain what these conditions are and what maybe is the biology of them. So we we have these resources available, I encourage you to take advantage of those. So what's in concluding here, the ordering and testing process? You can visit and order the panel through our online portal. The pricing of the panel is $9.95. We do ask for a deposit up front. We do bill for insurance too, so we do get some insurance reimbursement, and then we refund any deposit that is appropriate. For FedEx, it is traveled overnight to us, and there are certain conditions that we want you to do in order to send it to us. And then the antibodies that we'll test here generally take 2 to 3 weeks against these brain targets. We then publish the results. They will be on the portal and they'll be notified if you get that. We also courtesy bill patients' medical insurance. And then as a clinician, you'll be notified that the online report is available. You can again access consultation at the numbers that I provided there. So identifying the root is critical, and I'm going to end with this TAC law that I modified from Dr. Sidney Baker, a pediatrician involved in the Defeat Autism Now. He said, if you're sitting on a TAC, the treatment is not 2 Advil every 3 to 4 hours. You might liken this to, we're going to treat patients with neuropsychiatric disorders. It's not necessarily always just treating the symptoms. The treatment for TAC sitting is TAC removal. And then the goal really is to look for the root and treat the cause rather than the symptoms. And then the corollary to the second TAC law is if you're sitting on 2 TACs, removing 1 TAC doesn't eliminate 50% of the symptoms. So again, remember this is an infection-triggered autoimmune condition. Oftentimes, if you treat just the immune system but don't remove the infections or eliminate the infections, patient might improve for a while but may regress or may not completely get well. Complex conditions are complex. And so to be effective, need to address all the underlying issues. And infection-triggered autoimmune neuropsychiatric disorders are complex, but they are treatable. And we've got hundreds of stories of patients that we work with and physicians who now have used the test effectively and then identified patients in doing so to get them well. So with that, I'm going to conclude, but I want to thank you, the frontline physicians, you who are taking care of your patients as clinicians, because we do know that these patients are suffering from these disorders, and it greatly impacts their lives. But we know that you're working very hard and diligently to find answers for them. So we can be of any help. We now have over 1,900 doctors who have placed orders, over 13,000 patients we've tested and treated, and we look forward to helping you in any way that we can. And so, Amy, I will turn that back over to you.
Thank you, Dr. Shimasaki. We do have a few questions. The first one is, how do you know if a patient is appropriate for Cunningham panel testing?
Yeah, so a couple things. First of all, the testing itself is not a diagnostic, quote unquote, diagnostic. Testing and these diagnoses are clinical diagnoses, but this is an aid. So having said that, you're looking again for patients that either have, you've ruled out anything else, maybe they're not responsive to what you might think is traditional therapy for them, have some of these other symptoms, such as this relapsing remitting condition, many of these other symptoms that were described in these commonalities. Again, this webinar will be sent to you afterwards, so you can listen to it at your leisure. But generally, you want to look to rule out other types of conditions. And there are other types of tests you can use, like testing for strep titers, looking for other infections. But basically, the hallmark is many of these symptoms that I described in that commonality where we see positives.
Thank you. Another question is, can the Cunningham panel be useful for adults?
Absolutely. You know, we mentioned pediatrics, and actually it seems to be more severe in children, but predominantly in the beginning, we were receiving requests for testing for children, but 30% of our orders now are coming from adults. And often adults are very good at either concealing, hiding, or managing symptoms, but they also know that this is also something that is quote unquote not normal. And so we do find this effective in adults. One of the things that we are working on is to do larger studies in adults. But yes, it can be effective with one caveat, is that the normal controls that we have tested and are listed on the report are from pediatric controls. Now, we do find that there's similarities in these controls with adults, but it is possible that there might be slightly more elevated controls in adults, but that will also be a part of what we'll put out there and publish in the near future. But in the meantime, clinicians have found it to be effective and helpful in the diagnosis of these for adults.
Another question is, will antibiotics or psychiatric medicines interfere with Cunningham panel testing?
Because what we are looking at is the circulating level of antibodies present at the time of the blood draw. Any type of therapy that would interfere with the immune system or the production of those antibodies could potentially interfere. Now, the question about antibiotics is we do not find that to be the case. Antibiotics don't interfere directly with the test. Now, one of the things that antibiotics do is they remove the infection that might be triggering these antibodies. So a good rule of thumb is if your patient is symptomatic and they are demonstrating these symptoms, then at least there's good likelihood that these antibodies, if there, will be at a high enough level that we'll be able to pick them up. But the antibiotics themselves do not. Now, the other question would be what therapies do interfere. Immunomodulatory therapy can interfere in the sense where, let's say, intravenous immunoglobulin is used. For various reasons, I won't go into great detail, but it's from 1,000 patients or thousands of patients in many cases. And in some cases, some of these patients have some of these anti-neuronal antibodies. So we want to measure endogenous antibodies, not exogenous antibodies. So things that affect the immune system, including maybe very high dose or what we might call the high dose therapy for steroids, can suppress the immune system. So mostly think of it, if it's an immune modulatory therapy and the patient's symptoms have subsided, then it could interfere with it, or it could give you a false reading.
Another doctor asks, what if the person does not have strep?
Yeah. So this kind of leads to the overall confusion with pandas and what maybe some still think of as controversy. If you don't have strep, you don't have pandas. By definition, that's true. There's a couple of things I'll comment to that is, again, pandas refers to strep in children, but strep can be found in any orifice in the body, whether it's in nasopharynx, anal, perianal, vaginal. So that's one thing. The other is often it's not just necessarily strep, which is why the term PANS was coined. So PANS would refer to the others, such as Babesia, Bartonella, Lyme, Coxsackie virus. And again, many of these are highly associated with similar triggers. So if you don't find strep, or you don't find ASO or DNase-B titers that are high, then maybe you want to look for some of these other common infections that are associated with these neuropsychiatric symptoms of patients.
Dr. Shimasaki, our final question has to do with the cost of the Cunningham panel. Could you review the cost and perhaps explain why someone might consider it an expensive test?
Sure. Well, our goal, and we would love to be able to do this at no cost. I like to tell people we're a nonprofit organization, but not on purpose. It's because the test cost doesn't cover our costs. So we do go out and we raise money. We also have groups that help to fund tests for patients, but $9.95 is the pricing for the test. We also bill for insurance on behalf of the patient. And so many times we do find that insurance will cover sometimes all of it, sometimes a part of it, or sometimes it goes to deductible. We are working to try to find ways to help in reimbursement. There are groups that are also raising money to help support tests for patients in need. But if you think about many of these patients who have gone through multiple doctors with multiple medications, with multiple treatments over many years, that wouldn't it be great if the first thing they did was to find out whether or not this was autoimmune and begin that treatment immediately. So our goal is to do what we can, but also what we want to be able to do is continue to be testing.
Thank you, Dr. Shimasaki, and thank you everyone for joining our webinar today. As a reminder, you will be emailed a recording of this presentation within the next 2 to 3 days. If you have any further questions or would like to schedule a one-on-one discussion with a member of our clinical staff, please check the chat box for contact information. Thank you very much for attending this webinar, and we look forward to connecting with each of you soon.
Thank you.
Thank you. Goodbye.